Hello everyone. Once again, this is Dr. Abraham from A&E Dermatology. Today we are looking at Pyoderma Gangrenosum. Join me as we learn about this condition. So, Pyoderma Gangrenosum, what do we know about this condition? What have you heard? So in this picture, I want you to keep this picture as the memory of your brain. This is the before picture. We are seeing this patient with an ulcer on the scalp. Then after treatment, after 1 month, we see at least there's some sign of healing and scar formation. So in your case, what would you think this is? Think about it and then maybe let me know in the comments. So what do you know about Pyoderma gangrenosum? So Pyoderma gangrenosum in dermatology, it falls under a group category of conditions we call neutrophilic dermatosis, and it is uncommon but chronic and recurrent cutaneous ulcerative disease with a distinctive morphology and presentation. So the term Pyoderma gangrenosum was first coined by Bruce Ting and the colleagues in the 1930s. However, the disease had been described earlier on in different publications starting from the years of 1906. And this Pyoderma gangrenosum is a very common condition and it occurs globally. And it can affect any person at any age. It doesn't have any age restriction, though it is more common in women with the ages between 20 to 50 years. So we realize that 50% of these patients with Pyoderma gangrenosum, most likely if you investigate, they usually have an underlying condition, which is usually, it can be inflammatory bowel disease, it can be arthritis, inflammatory arthritis, or even a malignant disorder, more especially hematological malignancies, including acute myeloid leukemia and chronic myeloid leukemia and the rest. This case has also been reported in children and infants, though it is rare in this age group, and the cases reported only contribute to 4% of the total cases reported for Pyoderma gangrenosum. When we go to the pathogenesis or how this condition comes about, its pathogenesis is not well understood up to date. And in history, at first, people used to think it is an infectious process, but it is until when they were giving a lot of antibiotics, but no improvement, then the line of thought had to change to a defect in cell-mediated immunity, which most likely was predominated by neutrophils and monocytes. And currently, we still think most likely it may be an autoimmune or autoinflammatory condition whereby neutrophils, monocyte, and the humoral immunity has a role to play. This has been backed by different studies. We've seen some publications showing that in skin biopsies, of these lesions, when they examine the cells in those biopsies, they see that there's an increased expression of particular inflammatory molecules ranging from interleukin-1, interleukin-1 beta, the interleukin-1 receptor, interleukin-8. This is an attractant for neutrophils, interleukin-17, T1 necrosis factor alpha. All these molecules have been shown to increase in lesional skin or in skin biopsies of these samples with patients having Pyoderma gangrenosum. So it is because of this that we now think there is a role played by interleukin-1 pathway in the progression and development of Pyoderma gangrenosum. So in this schematic diagram, we are trying to understand the pathogenesis of this disease. So what we know right now is that it may be due to a trigger which we are not certain. This trigger may be internal or even external, including things like trauma, including things like infection or viral infections, but we are not certain which a particular trigger it is. But whatever it is, this trigger activates both the innate immune system and adaptive immune system of the skin. And because of this activation, we have also, we think that this trigger also may cause death of keratinocytes, early death of these keratinocytes, what we call apoptosis. This results into maybe activation of toll-like receptors, the dumps and the pumps. So this activates the innate immune system, and the net effect of this is production of inflammatory cytokines. These inflammatory cytokines will include the tumor necrosis factor, will include the interleukin 8 and the rest. So all these, what they do is that they cause recruitment of neutrophils in this area that is being affected, and it is because of this abnormal neutrophilic recruitment or dysfunction that we will think that this condition comes into existence. But all these are still theories. There's no concrete evidence to show actually to show what triggers or what causes the condition. But since Pyoderma gangrenosum has been implicated or seen in other syndromic presentations like the Papa syndrome, the Papash syndrome, and Sapo syndrome, we think that there may be a genetic background because of the syndromic nature of some cases of Pyoderma gangrenosum. But still, most other cases don't have any syndrome, so maybe or maybe not, genetics has a role to play. And then when you go to the clinical presentation, Pyoderma gangrenosum, usually it has 4 major clinical forms it presents with. The first one being ulcerative, we have the bullous, pustular, and then the vegetative form. Usually, the initial lesion in this condition is a pustule, which is on an erythematous base, and this pustule will rapidly progress to either to form a vesicle or bully, which ruptures, giving rise to a rapidly progressive ulcer, which usually has a characteristic appearance. These ulcers usually have an undermined border, and the base of this ulcer is usually purulent or even vegetative, depending on the variant you are dealing with. So to show you, this is dermatology in African skin, so we're using mostly patients that we see at the clinic. So in this ulcerative type of Pyoderma gangrenosum, you will see a purulent necrotic ulcer with red undermined borders, the way you see this ulcer in the picture. So this is the base that is reddish, and then you can see around here, this looks purulent, and this is the border of the ulcer on this leg of this gentleman. So this ulcerative type of Pyoderma gangrenosum usually favors the trunk, the lower limbs, and in most cases, patients can either have a single ulcer or even multiple. Like in this case that you see here, there's that ulcer that was healing, there's this ulcer that had healed. So this patient had multiple ulcers occurring at different times. Then what you have to understand is that this ulcerative type of Pyoderma gangrenosum, also called the typical type, usually progresses rapidly, and it has also been seen to be either idiopathic or secondary to trauma. And it has been associated with the inflammatory bowel disease, inflammatory rheumatoid arthritis, and myeloproliferative disorders like acute myeloid leukemia and chronic myeloid leukemia. The next variant, we call it the vesiculobullous variant, or a typical Pyoderma gangrenosum, or just simply bullous Pyoderma gangrenosum. And in this case, the patient will have grouped erythematous vesicles, which are usually surrounded by a blue-gray border, and usually when they necrotize or when these vesicles rupture, they give rise to a shell ulcer, as opposed to the ulcerative type where the ulcer is a little bit deeper. And these lesions usually favor the face and upper extremities, most commonly seen in settings of hematological malignancies. When you go to the next one, we call it the pustule variant of Pyoderma gangrenosum. In this case, the patient will have multiple small stellar pustules, and this case is, in some cases, they can even regress without treatment and even without scarring. But in most cases, they can even evolve to give you the classic type of Pyoderma gangrenosum. And this one still is observed in patient with IBD. So when you go to the next type, we call it the vegetative type of Pyoderma gangrenosum. And this type, it is also called the superficial granulomatous Pyoderma gangrenosum. In this case, it's usually localized, and it has this vegetative nature, as you can see in this picture, this vegetative part of the ulcer, and the ulcer is usually also superficial. So this is healing, this is scar tissue here. And This one has been shown to follow trauma, especially surgery, and it is a good type because it responds well to even less aggressive treatment like only topical corticosteroids. The other type that we usually see in patients with the IBD is what we call the pyoderma vectans, also seen in oral mucosa. So in this case, you find patients having vegetative lesions in the oral cavity and the lab and the lips, and this one can sometimes be studied, though they can be having pustules within the lesions, and it is mostly seen in patients with inflammatory bowel disease, especially the ulcerative type. So this picture here, you can go through it in your free time, but it just summarizes what we've been talking about. The subtype, the ulcerative type, commonly seen in these conditions, and usually it is rapidly progressing. Then we have the pustule type, commonly seen on the trunk and extensor surfaces, seen in patients with IBD, and frequently occurs with acute exacerbation of inflammatory bowel disease. And the bullous type usually have those grouped brass or grouped vesicles or bully, loves the face, those types of the hands, and seen in hematological malignancies. The vegetative type, usually a little bit painless, loves the face and neck and trunk, and this one slowly progressing. So when you go to this particular age group, the infants and children, we've seen that earlier that less than 50% of cases have been reported in patients aged 18 and below. And this is very key that sometimes when it occurs in children, people think it is something else, maybe an infection, maybe it's something else. But you have to think about Pyoderma gangrenosum if you find a child having a rapidly growing ulcer. So you find that the presentation is common, it's similar to what we see in adults, but for children, if you have a child, usually the lesions will have the face and the neck. If it is an infant, you look at the perineum and the buttocks. That's where you'll see such lesions. And still, in most of the cases, they'll have a preceding pustule, and pathology will be positive in more than 50%. So the pathology test that we talk about in Pyoderma gangrenosum simply means you get, you incite violence on someone's skin, you get something sharp, you create a wound, and then you observe. So if they have Pyoderma gangrenosum, you find that even that area where you've caused the trauma, the ulcer will develop and grow very fast. So although this test is very hard to do and we wouldn't advise you to do it, but still, it used to be done in those olden age to confirm the diagnosis or to know that the patient had Pyoderma gangrenosum. But still in children, this condition has been associated with inflammatory bowel disease, inflammatory arthritis, and hematological disorders. So when you go to differentials, when you look at the early lesions of Pyoderma gangrenosum, you need to make sure that it is not an infection, it is not colitis, it is not a lymphoma, or any other conditions that can also present similarly, like Behçet's disease and Sweet syndrome. If it is the lead type where you have already the ulcer, you have to think about things like eczema, atypical mycobacterial infections like the broad ulcer, deep mycosis. You can think about parasitic infections like leishmaniasis, vesicular diseases like venous insufficient ulcers, and then granulomatosis. So all these should be in your mind every time you see a patient and you're suspecting Pyoderma gangrenosum. So you should also think about other things that can cause something similar. So this table helps us to classify the major differences that we think about in our patients with Pyoderma gangrenosum with bacterial infections, including this list, even severetic tumors, viral infections, including SSV, fungal infections, having all these deep fungal infections, the protozoa, having leishmania leading the table, and amoebiasis cutis. Then immune-mediated like vasculitis and all vasculopathies, Behçet's, and the rest. Then neutrophilic dermatosis like Sweet syndrome, which is in the same group with Pyoderma gangrenosum. Then you have vascular conditions like venous hypertension, arterial insufficiency. All these give rise to ulcers. Then it can also be a cancer, which is either squamous cell carcinoma, basal cell carcinoma, and the rest all can also be just exogenous, like in factitious stomatitis. Stomatitis that affect someone. In that case, where someone causes injury to their skin because of maybe psychotic problems. So when you're evaluating patients in pyoderma gangrenosum, one, you have to take a thorough history examination, and then after that, you have to take off a biopsy to do H&E staining. Sorry, in this case, you'll be looking out for neutrophilic infiltrate, but then you have to also take off a swab to make sure that you exclude infection. That is one of the minor criteria in the diagnosis of this condition. Then since we've seen it being associated with GIT symptoms, you need to do things like occult blood to make sure that there's no underlying GIT condition, and then colonoscopy and biopsy, liver function test are other additional tests that you can do to assess the digestive system. So we've also seen it being associated with hematological conditions. So you need to do a full blood count, peripheral smear, and then bone marrow in extent of cases to make sure someone has no underlying malignancy. So all this diagram is now showing you which assessment tools will you do in particular age groups. For example, if you have a patient less than 65 years, after taking history and examination, you need to take off a biopsy and make sure you rule out the other things you talked about. You need to check their blood to rule out any malignancy. You need to do age-appropriate malignancy screening. You need to evaluate them for arthritis because we've seen it being associated with arthritis. So this a picture can guide you depending on the category of the patient that you're dealing with. So when it comes to diagnosis of this condition, this is the current diagnostic criteria, which has one major criterion and then a few minor criteria. So in the major criterion, we see that you have to take off a biopsy at the edge of the lesion, and then it has to demonstrate neutrophilic infiltrate. As we mentioned earlier, this condition is the neutrophilic dermatosis, meaning that it is driven around neutrophils, and we think there's a neutrophilic dysfunction. So in the biopsy, when you take off the sample, you'll see neutrophilic infiltrate, which is usually perifollicular, but then in that case, you will not be able to see colonies of bacteria. So that will make you think of pyoderma gangrenosum, since you are not able to see bacteria. But you know neutrophils come to fight bacterial infection. So you have neutrophils, but no bacteria. And then in the minor criteria, if you're able to exclude infection on your culture and sensitivity, you have done your pathology test, I've already talked about it. Then if a patient has a history of IBD and they get this ulcer, you have to think about pyoderma gangrenosum, and it is one of the minor criteria. So if someone has a history of a papule, pustule, or even a vesicle ulcerating within 4 days of appearing, very fast, rapidly developing ulcer, then you have to think about pyoderma gangrenosum. Then if someone has peripheral erythema, undermined border, tenderness at the site of the ulcer, all these are features of these ulcers that we see that in PG. And mouth ulceration, at least one on the lower leg, is also part of the minor criteria. If someone has wrinkled paper-like scar or healed sites like the way we saw in our patient up there, this is also a minor criteria. And then if the ulcer decreases in size within 1 month of treatment, like the first picture I showed you, within 1 month, the ulcer had started to heal. So that is part of the diagnostic criteria. So in this case, we are using response to treatment to be part of the diagnostic criteria. So in pathology, as I had mentioned earlier, it is usually unspecific because you cannot use it to confirm, but it is very key in making the diagnosis, because if you get the early pyoderma gangrenosum, you'll be able to see neutrophilic infiltrate, which usually love to be around the vessels and around the air follicles. So that's what we call folliculocentric, or you see them around the blood vessels. So this infiltrate usually has neutrophils purely without bacteria. So if you look at this, you see this is a very busy dermis, very busy dermis. So this is blood, this is blood. So you have lost the epidermis up there. So this is an ulcer You've lost the epidermis up there. You don't have this in the normal stratum corneum, the normal basket with pattern, but you have this very dense infiltrate of neutrophils. If you look at this close up here, these are neutrophils that are infiltrating your sample. So this is what we'll see on pathology. Then what do we have in treatment options? So this is the picture of someone who had ill, and when you look at that ulcer or that healed scar, you see that paper-like or described what we have described here as in our minor criteria as cribriform or wrinkled paper-like scar. So this is what you're seeing here in this picture. If you have to look at this, that is characteristic for Pyoderma Gangrenosum. So in the treatment option, the main goal is to make sure that that wound heals. Of course, that's what the patient wants, to get rid of this wound. And in treatment approaches, we can use either topical, intralesional, or even systemic medication. The first line therapy is oral cyclosporine. So this one is dosed depending on someone's kilogram weight, but the range is between 50 to 100 milligrams twice a day. And then this course duration is varied. You can start high up there and then you taper down. And then the other drug that we usually use are oral corticosteroids, the prednisolone. We can start as high as 60 or 80 or even 120 if the lesions are extensive. So after control, then we taper down and then we continue with cyclosporine until when the wounds have cleared. So we have some new developments in medication where we have now new biologicals on market like infliximab. And this one has level 1 evidence that it cures. We've had clinical improvement when treating patients with Pyoderma Gangrenosum. And the new molecule that is being tried currently is called vilobelimab, which is anti-complement factor 5 inhibitor, and it has shown progress. So later on, we shall start using it maybe, though not really available in our setting. But what you have to understand that in this case, in these wounds, avoid surgery as much as possible. Do not debride the wound. Do not tamper with the wound because that worsens the condition. So these are the medications summarized: topical medication, and then the level of evidence of how strong they are. And in the topicals, the one that is strong is corticosteroids have been tried, tacrolimus, even phenytoin topically. All these are at level 4 of evidence. And then intralesional corticosteroids only. And then in the systemic one, I want you to take note at our cyclosporine, which is the first line, and the corticosteroid, which is oral prednisolone. So those two drugs, I'll just remember them when you're managing this condition. And it is, since it is also a neutrophilic dermatosis, even dapsone can also be tried either as in combination with the other drugs. Then other molecules which can be tried to have methotrexate, mycophenolate mofetil has been reported in some anecdotal data that it has been effective. Even thalidomide has also been tried. So the current trend, the new biologicals, we have infliximab as the number 1 with level 1 evidence, but others that have been tried, we have adalimumab, etanercept, and then all these are tumor necrosis factor alpha inhibitors, and then we have anacrinum, which is the interleukin-1 inhibitor, and then secukinumab, which is the interleukin-12 and 23 inhibitor. So these are the biologicals that are currently being investigated, on top of which we have the complement factor 5 inhibitor, this one, okay, vilobelimab. Okay. So now, as I conclude, I wanted to take you through this schematic diagram of how this disease has been described and how theories have been changing over time. So if you have to start with me here, in the 1908, that's when it was first described, being given the first name, the geometric phagetism. So after this description, this description became because of how the ulcers were looking with the clear-cut border, margin, and the flow. The flow was usually purulent with undermined borders, which usually had like pus-like discharge, and then that erythematous border, which was like overhanging border. So that's why it was called that. Then later on, In the 1930s, Brusting and a colleague now named it Pyoderma Gangrenosum, and realized that all through starting from the 1980 and 1908, all the way through up to 1964, people thought that it was an infectious condition, so they were giving antibiotics. But all these years, there was no improvement until when someone decided to try. What if I give corticosteroid? So in the 1956, we tried to give corticosteroid, and when that happened, people started to see, hey, as if there's improvement. So people started to try other immune modulators, like other thiopurine. And then later on, because there was no improvement, then we're like, no, it has to be something else. Then we started thinking that, oh no, this condition may be immunological. So we started to give immune modulators. So in the 1985, that's when we report the very first case where we treated Pyoderma Gangrenosum with cyclosporine. And ever since then, cyclosporine has been reported in different clinical trials to be very, very good in this condition. And then later on, in 2006, now we've introduced the new biological, the infliximab, being very, very effective. So we have here corticosteroid starting in first, cyclosporine, and the infliximab. And currently, the current theory is Pyoderma gangrenosum is an autoinflammatory condition with involvement of the neutrophils and monocytes together with death or apoptosis of keratinocytes, activation of innate immune system, activation of the adaptive immune system, secondary to unknown trigger. But this trigger is thought to be either external or internal. No one knows. Imagine in that area, we are still all idiots or idiopathic. So I would like to thank you very much for following us through, but then I will encourage you to subscribe to this channel, then share with your colleagues so that we learn together as we dive deep in dermatology. So this channel will have our dermatology in African skin. So this is purely made for African skin. Thank you very much. God bless you.